Hello. Tonight with me, it's firstly a very good friend, Yiannis Sotiralis, and secondly, a very good physiotherapist. Yiannis, he's with us, I think, 7 years now.
7 years.
And he's one of the most resilient persons that I know. And one of the persons that are very focused on personal development. And last year, it was the year when you choose to go in Belgium and give an exam to the European Federation for Pain Science.
Yes.
And after you pass this exam, now you are one of the few physiotherapists in Europe.
In Greece.
And in Greece, definitely, because there are only two of you. Three now. Okay. Which are considered a pain specialist, a physiotherapist and pain specialist in the same time. And
accredited from the EFIC organization.
From the EFIC organization, which is a part of IASP. Tell us, why did you felt that this is an important step in your development as a physiotherapist?
Look, I always have been a physical therapist with an interest in pain science. I think that the majority of our patients visit a physical therapy practice for two main reasons. A dysfunction that bothers them, and this dysfunction usually is accompanied by a pain experience. So I think that we have to have a thorough look into what pain experience is for these people. And I think not only for me, which definitely was a major thing for me to decide to have this experience and to go to a deeper understanding in the pain science and in the pain experience of my patients. But I would suggest and I would say that this is a procedure that I hope a lot of our colleagues decide to follow. This is also a strategy, if you want, or a naming of EFIC. At the moment, there are 3 or 4 professions, I think. It's medical doctors, nurses, psychologists, and physical therapists that they engage themselves in this procedure. And this is a very good start to create a common terminology that, as we discussed also a lot of times together and before, plays a big role to how do we approach our patients, how do we treat them, and also from the medical point of view, what kind of drugs the doctor prescribes to them, so to be the proper drugs depending their pain experience.
This is a very important thing and I want to go back to it, but I will go a little bit backwards to what you said. So EFIC choose doctors, choose psychologists, choose nurses and physical therapists.
At the moment, at least.
For the moment, as health professions
that are straight related with
pain experiences.
So, and they deal with a lot of patients with this.
Because we talk a lot about interdisciplinary work and multidisciplinary team, and we see that it's not only our will in being a part of it. People already see us.
Yes, and we have, as you already told, that we try to move from multidisciplinary to interdisciplinary. There is a big difference, at least in English language, to this, because this means that the team is for real working with each other, and every scientist of the team knows the trajectory of the patient's health issues and pain, and all of them try to work together.
So they are not only more than one, they are also working together towards a common goal and the benefits of the patient at the end of the day.
Because as you know, especially for the chronic pain patient, we're talking still about pain management and not necessarily a pain treatment, which is definitely our goal, but we have a lot of road to reach this destination.
Just for the people that are watching, why is it so difficult to talk about treatment when we talk about chronic patients?
Because if we are talking about the real chronic pain patients, we are talking about what our new terminology, our new term that has been proposed from IASP is the term of nociplastic pain or of central pain-related syndromes, which means that we don't really have a tissue at the moment with a known dysfunction or with a known pathology, but the nociceptive apparatus itself has a problem of interpreting
a little glitch.
Proper, yes, it's like a glitch, the proper signaling, and we have pain experience without having a real, if you want, the pain is real, but we're not in a position
exactly
to see what pathology, if there is a pathology. Maybe there is not a pathology, and as you said, it's a glitch of the system. So that's why we're talking about pain management strategies. There are scientific works at the moment aiming for the creation of new drugs. We have some clues, if you want, some primary data from immune system participation in the pain experience, from glial cells, astrocytes, and another number of cells that probably they are playing a role in the intracellular signaling, but we are, I think, some years before.
At the beginning of this type of research. But as you describe it, it's a very deep dive into the human biology, human chemistry, and physiology.
Yes, so that's why we have so many different professions integrate their knowledge to this frame.
What can you tell us about persistent pain? Is there a difference between a persistent pain and chronic pain?
Now you are entering to the problems of terminology, as we have been discussed before. Practically, there is a difference. Persistent pain is something that you can describe as a person having pain for a lot of time. But if this pain, from an approach, from a physical therapy approach, from the drug approach, suddenly becomes better and better and disappears, then we are not talking about the real chronic pain situation where the data that we are having is not so good, if you want, at the moment. So long persistent pain, maybe it's a pain that it's never been handled correct or misdiagnosed, or he didn't have the approach to health system to be helped and to be relieved from this pain. While chronic pain is the thing that we discussed before. There are nociplastic changes that make the person feel pain practically continuously.
If we would like to explain to our patients in very basic and simple words what is pain, because pain, it's something very real for each of us, but in the same time, we know that pain is not something from the outside. It's something from inside out.
From the inside, yeah.
How would you explain to a patient in very easy to understand words about his or her pain?
Now, this is not maybe it seems like an easy question. It's not.
No, I know it's not.
It's not an easy question because we have tried to give simple explanations before, and from our research, we don't really have the data to support that this works in every time. So the thing that I can tell you at the moment is that we as profession, physical therapists and the other health professions, have to be able to evolve and to be better in our communicative skills with our patients, be able to adapt to their level of understanding. All of our patients, they're not having the same level of health literacy or the same level of understanding. So we have to adapt and to give explanations in a meaningful way for them. And this is something that I don't really believe that we can put it in boxes. We can have a strategy that probably guides them to a way of managing and improving their quality of life at first, and minimize their fear and catastrophizing thoughts that these patients are usually have. And all of us, me, you, the scientific community and the patients, of course, give science some time to improve also pharmaceutical targeting, which is the only thing, to my opinion, and to a lot of other scientists' opinion, that it will help, at least in the how much pain the patient described is having.
You touch a very sensitive topic, the idea of catastrophization. How big is our role as a specialist in this idea of?
I would say that catastrophizing, catastrophizing and improving behaviors of fear avoidance is one of the major goals that the physical therapist should try to engage himself when he is dealing with a patient with chronic pain. Of course, to this, there are limitations, because there are patients that they will need also psychological help from a specialist, a psychologist, or even some drug assistance. If there are depression states or bipolar disorder states or other psychological issues, that they will need also a drug assistant. But from our point of view of handling pain and handling movement, which is the area of our interest, yes, we can definitely help them to be less afraid of the movement that they are doing in everyday practice, and less catastrophizing of what is going to happen if they do this movement. That practically there are not a lot of things that could go wrong. There are flare-ups or flare-downs of the pain experience itself, but it's in our way of communication with them to help them.
But this also puts us in
the very difficult and responsible position.
Yes, in the middle position, because with our words and our actions, don't do that. We
Definitely.
can make the patient be in the side where he's ruining his life or her life, or we can be on the opposite side, so we can be the good devil or the bad angel.
Yes, exactly. It's exactly. And you have to be able to understand when there is a small time for take a little care more. For example, after a surgery, maybe you will need a time to be cautious and to avoid some movements. But generally, this is not the usual case. And generally, we try to encourage patients to move with safety, but to be gradually more functional and more enjoy their lives and to improve their level of everyday activities.
I think that the information that you are providing, it's excellent. And before we stop this discussion, can you please tell to the listeners, to the viewers, what is pain? It's a sensation or a perception?
Now you are talking to a big debate that exists in the internet. I would say to you my opinion. I don't really think that this is something that it's of a big interest for the patients themselves, because the patients
it's more for us.
Always, yes. The big questions that they have is, what can you do to help me with my pain? Mm-hmm. And this is the main issue here. But if the pain is sensation or perception, I think it has already been answered, not by me, but by psychiatrists and other professions, that they first try to do the research and stuff like that. So practically, to make a long story short, from the point of the nociceptive coding until it reaches the thalamus, maybe, we call it sensation. And if this sensation reaches the level of consciousness, then we call it perception. This, I think, is the most, not accurate, but the opinion that at the moment is the most correct. Okay. But I am ready to change it if new data from the research tell us otherwise or give us new information about.
Thank you very much for the discussion, and thank you very much for the information that you provided. A big congratulations again, because you are willing on staying up to date all the time, and you are staying in the research as much as you can. And I hope to see you.
We will talk again. I hope it too. And I strongly believe that a lot of people a lot of colleagues from our profession should do this experience, to try to become pain experts, to get the pain diploma. It's a very good approach for their involvement and for their clinical practice to be improved.
Thank you very much.
You're welcome.